Good day, everybody. Our group will be presenting about acute bone and joint infections in pediatrics. The objectives of this presentation are: first, to discuss clinical and non-clinical presentations of acute bone and joint infections in pediatrics, and second, to discuss the most recent evidence-based recommendations and appropriate anti-infective therapy. Acute bone and joint infections in children may clinically occur as osteomyelitis or septic arthritis. In clinical practice, one-third of cases present a combination of both conditions, and this combination may occur in as many as 75% of cases in newborn. Bone and joint infections are usually caused by the hematogenous dissemination of septic emboli, which means that a spread of infectious organisms into the bone and joints from the blood carried to the terminal blood vessels of bone and joints from distant infectious processes during transient bacteremia. Bone and joint infections can be classified as acute with an onset duration of greater than 2 weeks, subacute greater than 3 months, and chronic lesser than 3 months. Chronic and subacute infections are common in adults, while chronic infections are relatively rare conditions in pediatric patients, which can be caused by the establishment of biofilm, and different surgical approaches must be considered. Osteomyelitis is defined as an inflammation or swelling that occurs in the bone. It can result from an infection somewhere else in the body that has spread to the bone, or it can start in the bone, often as a result of an injury. It occurs more common in younger children who are 5 years of age and younger, but can happen at any age. Boys are usually more affected than girls. Antibiotics are prescribed to treat osteomyelitis, but surgery may also be recommended in certain cases. This is a table of the clinical symptoms of osteomyelitis in different age groups, starting from neonate, young child, and older child. In neonates, systemic symptoms are fever, irritability, poor feeding, and it's difficult to distinguish from other infections at this age. Local symptoms are widespread limb pain, and it is difficult to localize on examination, bone or limb swelling, erythema, pseudoparalysis, and can have no local signs, especially when flat bones are affected. In the young child age group, systemic symptoms are vomiting, poor feeding, irritability in young infants with fever, but not necessarily always present in most cases, but may be the only symptom. Systemic symptoms in septic arthritis are usually more severe. Local symptoms may or may not have local signs: refusal to bear weight or sit down, limping, limb swelling, and erythema. In older child age group, systemic symptoms are same as young child. Local symptoms includes limping, pain or more localized, bone or limb swelling, erythema. Older children tend to localize more the symptomatology. Most common causes of bacterial osteomyelitis in children according to age. Age of less than 3 months, Staphylococcus aureus, either MSSA or MRSA. Group B Streptococcus, most likely the Streptococcus agalactiae and gram-negative bacilli. In 3 months to early childhood age group, Staphylococcus aureus, either MSSA or MRSA. Group A Streptococcus, most likely S. pyogenes, S. pneumoniae, and Kingella kigae, and the Haemophilus influenza type B. In older children and adolescents category, the most common causative agents are S. aureus, either MSSA and or MRSA, Group A Streptococcus, most likely S. pyogenes, and S. pneumoniae. For those under the age of 36 months or less, and children who are incompletely immunized against Haemophilus influenza type B, the most common causative agents are septic arthritis, MRSA, HIB itself. Surgical intervention of acute hematogenous osteomyelitis. Studies have shown that appropriate therapy alone without surgical intervention will suffice for 90% of cases of acute hematogenous osteomyelitis. In some cases of complicated acute hematogenous osteomyelitis, due to community-acquired MRSA, surgical incision and drainage, including multiple procedures, may be indicated. Management of osteomyelitis in children. Pre-treatment evaluation is gathered before initiating empiric antimicrobial therapy, and cultures should be obtained from blood and suspected foci of infection. A minimum of 1 blood culture, but preferably 2, should be obtained. Empiric antimicrobial therapy is adjusted according to clinical response and cultural unsusceptibility result. Empiric parenteral therapy. Antimicrobial therapy for osteomyelitis should be initiated before the diagnosis is confirmed. Because the risk of delaying treatment for bacteremic patients may be significant, particularly for those with community-associated Staphylococcus aureus. In choosing the drug regimen, there are factors to be considered. First, initial antimicrobial therapy for acute hematogenous osteomyelitis usually is administered parenterally. The empiric regimen is determined by the most likely pathogens and antimicrobial susceptibilities based on epidemiologic factors. Empiric antimicrobial therapy for infants less than 3 months of age with acute hematogenous osteomyelitis. First to consider is that antimicrobial therapy of activity must have a coverage against S. aureus, a gram-negative bacilli, and group B Staphylococcus. Second is to consider if the infant have signs of sepsis like tachycardia, poor perfusion, and hypotension. If yes, then the drug regimen should include vancomycin plus oxacillin or nafcillin plus with any of the following: cefotaxime, ceftazidime, ceftriaxone, or vancomycin plus cefepime. Next factor to consider is to note if the infant is at increased risk for MRSA or CONS, which means coagulase negative staphylococci, with any of the following conditions: ICU care for more than 1 week, mother has or suspected to have infection or colonization, with community-acquired S. aureus, is MRSA infection common at the admitting hospital, prematurity of the infant, prolonged or recurrent bacteremia with CONS despite antibiotic therapy. If one or more of these factors is a yes, then the empiric therapy should include vancomycin plus one of the following: cefotaxime, which is preferred if available, ceftazidime, ceftriaxone, and cefepime. If the answer is no, then the empiric therapy should include vancomycin or nafcillin or oxacillin, plus one of the following: cefotaxime, if available, which is preferred, ceftazidime, ceftriaxone, or monotherapy with cefepime. Empiric antimicrobial therapy for children more than 3 months of age with acute hematogenous osteomyelitis. Empiric antimicrobial therapy should have activity against S. aureus, other gram-positive pathogens like group A Streptococcus, Streptococcus pneumoniae, and other pathogen, if indicated to the table list on the next few slides. Next is to consider whether the child have life-threatening infection like signs of sepsis. If yes, then the empiric antimicrobial therapy should include vancomycin plus any of the following: oxacillin and nafcillin, plus, if indicated, additional coverage for other pathogens which may get into the next few slides for the table. If the answer is no, then consider if there is an increased prevalence of MRSA in the community. If warranted, are there any of the following risk factors for clindamycin resistance, MRSA in the community? If no, then the empiric therapy includes one of the following: nafcillin, oxacillin, cefazolin, plus, if indicated, an additional coverage for other pathogens. If the answer is yes to the question of the risk factors for clindamycin-resistant MRSA, then the empiric therapy should include vancomycin plus additional coverage for other pathogens. If no, empiric therapy includes clindamycin plus, if indicated, additional coverage for other pathogens. empiric antimicrobial therapy for children more than 3 months of age with acute hematogenous osteomyelitis. For the age group of 6 to 36 months and in daycare or history of oral ulcers before onset of musculoskeletal symptoms, potential pathogen is King-A and the additional empiric therapy is cefazolin if the child is not improving as expected and is receiving vancomycin or clindamycin. Next are those children less than 2 years of age with incomplete Haemophilus influenza type B. Next are those people with sickle cell disease, reptile or amphibian exposure, GI symptoms. The potential pathogen for the infection is Salmonella. Next is people with chronic granulomatous disease. The potential pathogen is unusual organisms like fungi, filamentous bacterium, gram-negative bacteria. Starting from the age group of less than 2 years of age with incomplete Haemophilus influenza type B vaccination, down to people with chronic granulomatous disease, the additional empiric therapy is either cefotaxime or ceftriaxone. Next is people with GI surgery or complex urinary tract anatomy. The potential pathogen is an enteric gram-negative organism. Empiric therapy is either a third or fourth gen cephalosporin like cefotaxime, ceftriaxone, or cefepime, or an aminoglycoside like gentamicin. Suggested antimicrobial regimen for the most commonly isolated pathogens causing osteoarticular infections in infants and children when results of culture and susceptibility testing are known. Below is the table for the confirmed culture of pathogens with their respective parenteral agents and oral agents. For S. aureus, parenteral agent includes cefazolin, nafcillin, oxazolin, and for the oral agents, cefalexin, cloxazolin, dicloxazolin, and clindamycin. For methicillin-resistant pathogens like clindamycin susceptible, parenteral agents include vancomycin or clindamycin with an oral counterpart of clindamycin. For clindamycin-resistant, methicillin-resistant, parenteral agents include vancomycin, linezolid, or daptomycin, with linezolid as the oral counterpart. Under Group B Streptococcus, like S. agalactiae, penicillin through parenteral is the only route since oral therapy is not suggested in infants. Under Group A Streptococcus, like S. pyogenes, penicillin or ampicillin through parenteral is suggested while the oral counterpart is penicillin or amoxicillin. For pneumococcus like S. pneumoniae, for penicillin susceptible, penicillin is the oral counterpart while the oral counterpart is penicillin amoxicillin. For penicillin non-susceptible, the parenteral counterpart is cefotaxime, ceftriaxone, clindamycin, or linezolid, with the oral counterpart of clindamycin or linezolid. For King-A, the parenteral agents are penicillin, cefazolin, cefotaxime, or ceftriaxone, with the oral counterpart of penicillin, cefalexin, or cefixime. For the Haemophilus influenza type B, the parenteral agents are cefotaxime, ceftriaxone, or cefuroxime, the oral counterpart of amoxicillin, or cefixime. Septic arthritis is defined as an infection in the joint, most likely the synovial fluid and joint tissues. It occurs more in children than in adults. The infection usually reaches the joints through the bloodstream. In some cases, joints may become infected due to an injection or injury. Shown is an arrow chart for clinically diagnosing septic arthritis. It starts with the suspicion of septic arthritis. Symptoms include fever, inability to bear weight, painful range of motion, and swollen red joint with effusion, pain on passive joint movement. In newborns, irritability, malaise, vomiting, or refusal to eat. Next is to do physical exam, radiographs, order labs like CRP, ESR, CBC with DIF, and blood cultures. Next is to use the Kocher's criteria to assess the probability of septic arthritis and must have a score of more than 2 or equal to 3 or 4 for hip, or a CRP more than or equal to 2 mg per deciliter, or an ESR of more than or equal to 20 mm per hour for all joints. If the criteria are met, then proceed with joint aspiration. Use ultrasound guided for hip joints, US guided aspiration, send gram stain, culture and or PCR. Clinical suspicion of concomitant septic arthritis and osteomyelitis is to use urgent MRI, and also start empiric antibiotics. Next is to proceed to surgical irrigation and debridement. If the criteria is not met, ultrasound or MRI positive for joint effusion, then if confirmed that it is positive for joint effusion with positive gram stain or clinical suspicion of septic arthritis, start empiric antibiotics, then proceed to surgical irrigation and debridement. If ultrasound or MRI negative for joint effusion, monitor patient clinically, follow fever, CRP, WBC, and re-evaluate other potential differential diagnoses. These are clinical features with their respective bacterial pathogens that cause arthritis in children. Staph aureus affects all ages, may cause polyarticular infection, possible skin-associated or soft tissue infection. MRSA may be associated with venous thromboembolism and pulmonary disease. Next is the coagulase negative staphylococci or cons, most common cause of bacterial arthritis associated with prosthetic joints. Next is group A strep, like strep pyogenes, may occur as a complication of concurrent varicella-zoster infection. Next is strep pneumoniae. Children younger than 2 years of age are typically without risk factors for invasive pneumococcal disease and without extra-articular manifestations of pneumococcal disease. Group B strep, like strep agalactiae, infants younger than 3 months of age, usually in the ages of 2 to 4 weeks. For the nocardia asteroides, chronic monoarticular arthritis with granulomatous reaction. Most common causes of bacterial arthritis in children according to age. For the age group of less than 3 months, the most common bacteria are Staphylococcus aureus, either MSSA or MRSA, Group B strep, like strep agalactiae, a gram-negative bacilli, or the Neisseria gonorrhoeae. For the age group of 3 months to 3 years, the most common bacteria that causes bacterial arthritis are S. aureus, most likely MSSA and or MRSA, Kingella kingae, Group A strep like S. pyogenes, S. pneumoniae, and HIB in incompletely immunized children in regions with low HIB immunization rates. For the age group of more than 3 years, the most common bacteria that causes bacterial arthritis is or are S. aureus, either MSSA and or MRSA, Group A strep, S. pneumoniae, and N. gonorrhoeae in sexually active adolescents. These are the gram-negative bacteria that is the causative pathogen for some age groups or certain population. For the Kingella kingae, usually children up 6 months to 36 months of age are affected, with an indolent onset and the oral ulcers preceding musculoskeletal findings. For the HIB, this is for the incompletely immunized children in areas with low HIB immunization rates. The Neisseria gonorrhoeae affected the newborns, usually affects joints below the hip, may cause polyarticular infection. And for those sexually active adolescents infected by the Neisseria gonorrhoeae, usually occurs as part of disseminated infection with fever and rash. In females, may precede onset of menses. Neisseria meningitidis, may cause polyarticular infection. Petechial symptoms include petechial or purpuric rash. Post-infectious immune complex mediated arthritis may occur 2 to 3 weeks after infection. Salmonella species. Children with sickle disease or related hemoglobinopathies, exposure to reptiles or amphibians, children with GI symptoms, children in resource-limited countries. Non-salmonella gram-negative bacilli affected are the newborns, and people with instrumentation of the GI or urinary tract, people with immunocompromised hosts as host, open or penetrating trauma. For the Enterobacter cloacae, increases the risk of complications. For Pseudomonas aeruginosa, people with puncture wounds and people who are using injectable drugs. Strep moniliformis for rat bite fever caused by the rat bite presents with macular rash at time of presentation. Same with the Borrelia burgdorferi, which is the causative agent of Lyme disease, and Brucella, which is the causative agent of brucellosis. For the granulomatous arthritis, both Mycobacterium tuberculosis and non-tuberculous mycobacteria causes chronic monoarticular arthritis with granulomatous reaction. Same with coccidioides infection, may cause coccidioidomycosis and produces an indolent arthritis. Treatment of septic arthritis. Surgical intervention includes draining and irrigating the affected joint. Serial aspirations and lavage, arthrotomy, and arthroscopy have all been described as treatment modalities for patients with septic arthritis. Bacterial arthritis. Treatment and outcome in infants and children. Treatment should be started without delay after synovial fluid and blood samples have been obtained. Coverage for S. aureus, which is the most common cause of bacterial arthritis, should be included in the empiric therapy for children of all ages, with particular circumstance and gram stain. Empiric therapy can be altered with the susceptibility pattern of the causative bacterium is known. Recommended empiric antibiotic treatment for septic arthritis. Table below shows the local resistance pattern of S. aureus with the respective choice of antibiotics. For more than 90% methicillin sensitive, the choice of antibiotic is a first-gen cephalosporin or clindamycin. If it is less than 90% methicillin sensitive, choice of antibiotic is clindamycin. If it is less than 90% methicillin sensitive and less than 90% clindamycin sensitive, vancomycin is the choice of antibiotic. If there is vancomycin resistance, linezolid is the choice of antibiotic. Optimal length of antibiotic treatment for acute septic arthritis. Treated with antibiotic for 2 to 4 days. For uncomplicated septic arthritis, about 2 weeks duration. For septic arthritis and osteomyelitis, about 3 weeks. For methicillin-resistant S. aureus, about 3 to 4 weeks. Suggested empiric parenteral regimens for acute bacterial arthritis in children and adolescents. Both SA and OM have almost the same antibiotic empiric regimen since they both cover for the same pathogens with the exception of additional antibiotic therapy for a few circumstantial indication. For hemodynamically stable children, we suggest either clindamycin or vancomycin if more than 10% of community S. aureus isolates are methicillin resistant. Other experts may use a different threshold for methicillin resistance and more. For children younger than 3 months, empiric therapy for bacterial arthritis in infants less than 3 months of age should be directed against Staphylococcus, Group B Streptococcus, and gram-negative bacilli. Initial antimicrobial therapy for bacterial arthritis is usually administered parenterally. Potential regimens include an anti-staphylococcal agent like nafcillin, oxacillin, or vancomycin, plus cefotaxime if available, or ceftazidime or cefepime if Pseudomonas aeruginosa is a consideration, or if cefotaxime is not available, or ceftriaxone if cefotaxime and ceftazidime are not available, and the infant is not receiving intravenous calcium-containing solution. Gentamicin is a potential alternative to cephalosporins but will increase the risk of nephrotoxicity if given with vancomycin. Vancomycin rather than nafcillin or oxacillin should be included in the regimen for neonates less than 1 month of age who have been in the intensive care unit for more than 1 week because of the risk of health care-associated infection with methicillin-resistant S. aureus, or in communities where MRSA accounts for more than 10 to 15% of community S. aureus infection. For hemodynamically stable children more than 3 months of age, the antibiotic of choice if less than 10% of community S. aureus isolates or MRSA is either of the following: cefazolin, nafcillin, or oxacillin. Cefazolin provides coverage for key king A, example for children of 6 to 36 months of age who attend daycare or had oral ulcers before onset of musculoskeletal symptoms. For hemodynamically stable children, we suggest either clindamycin or vancomycin if more than 10% of community S. aureus isolates are methicillin resistant. Other experts may use a different threshold for methicillin resistance or more. Vancomycin is preferred for life-threatening infections in combination with oxacillin or nafcillin pending susceptible results. Vancomycin is preferred if more than 10% of community S. aureus isolates are clindamycin resistant, and lastly, it is preferred for children with prosthetic joint infection like Conn's coagulase negative staphylococci. The agent of choice depends on the severity of illness, local prevalence of community-associated MRSA, the susceptibility of community-acquired MRSA isolates to clindamycin, and suspicion for other pathogens. For the additional coverage as clinical indications, the following are the indications and their respective antibiotic agents. For gram-negative organisms on gram stain, the antibiotics are cefotaxime, ceftriaxone, or cefuroxime. For penetrating trauma or history of penetrating trauma, a polymicrobial including P. aeruginosa, the antibiotic agents are cefepime monotherapy or combination therapy with either cefepime or ceftazidime plus either clindamycin or vancomycin. For age 6 to 36 months and daycare attendance or history of oral ulcers before onset of musculoskeletal symptoms, kicking A, use cefazolin for anti-staphylococcal coverage if possible. For incomplete pneumococcal immunization in a child less than 2 years of age, or high-risk conditions for invasive pneumococcal disease, or antibiotic therapy within 4 weeks of diagnosis of bacterial arthritis, and for sickle disease or related hemoglobinopathies caused by salmonella, use cefotaxime or ceftriaxone. For patients with recent GI surgery or complex urinary tract anatomy, enteric gram-negative organism, use one of the following: cefotaxime, ceftriaxone, or cefepime if P. aeruginosa is a concern. For sexually active adolescent, Neisseria gonorrhoeae is most likely the causative agent. Ceftriaxone plus presumptive treatment for chlamydia. For injection drug user, P. aeruginosa is most likely the pathogen. Use ceftazidime. Alternatives to vancomycin and clindamycin when MRSA is a concern include linezolid or daptomycin if the child is more than 1 year of age and has no concomitant pulmonary involvement. Ceftaroline is active against many pathogens that cause septic arthritis in children and is under investigation for use in septic arthritis and osteomyelitis in children, but data are limited. This combination therapy broadly covers the most likely pathogens to cause septic arthritis and osteomyelitis complicated by septic shock, MRSA, MSSA, and Neisseria meningitidis. Nafcillin, oxacillin, or cefazolin are superior to vancomycin for treatment of serious MSSA infections. Ceftriaxone or cefepime provide activity against meningitidis. We provide empiric antimicrobial therapy for other pathogens as indicated. For children with septic arthritis and hemodynamic instability who are unable to tolerate penicillin and cephalosporin antibiotics, we use vancomycin in in combination with the carbapenem or a fluoroquinolone until gram-negative bacteremia is excluded. This is a table for suggested doses of parenteral antibiotics commonly used in the treatment of osteoarticular infections in infants and children.